Hi guys, with this getting started, so you haven't missed much, I'm just going to do a quick screen share so that you're all aware that you are in the right place. So we are going to get started soon. It's the AKT/RCA, also MSRA, Croup and smoking cessation teaching. We'll get started in the next 5 minutes, guys. So we're going to get the webinar started in about 2-3 minutes, waiting for a couple of people to join. If you've just joined us, if you don't mind, it's Dr. Mo here from Inspire Medics. There's a chat feature at the bottom of Zoom. And what if you can help us out by letting us know where you're joining us from and also which exam you're sitting, that'd be really, really useful. So my name's Dr. Mo. I'm joining you guys from Coventry, which is obviously based in the West Midlands, and I'm a qualified GP of 5 years. Dr. Sandhu's also just joined us as well, so he's on the other side of the screen. So we'll just give it a minute or two whilst everybody's joining us. You should be able to see us and hear us. If you can't, please let us know. And then if you don't mind giving us a quick intro in the chat box, where you're joining us from. What I'm going to do is a couple of things. One is we are recording this webinar, so we'll be uploading it onto YouTube. Vikas, if you can start doing the shout out, and I'll stream the Facebook group.
Brilliant. So yeah, if you just stream it to the Facebook, brilliant. So welcome, guys. So thank you for joining us to the Sunday evening AKT and RCA preparation webinar. You probably know the drill by now, which is 2 hot topics from the NICE CKS guidance, and then, you know, quick overview of the important learning points for you guys. So perfect. So guys, tell us where you're joining us from. So lots of you are starting to join. I think we've only just started. We've got 37 people already signed in, which is great. Chuma joining us from Lincolnshire. Welcome, Chuma. Rai Hamid Khan taking RCA East Lancashire. Fantastic. So not long. Dr. Alu Kayode from the RCA. Nandan from Coventry. Nandan, you'll be excited to know that both me and Dr. Mo are from Coventry. Whereabouts in Coventry and which surgery? I wonder if we know where you're based. Dr. Pramod Mummingati from Swansea, a GP ST3 doing the AKT in January. Fantastic. Welcome, Pramod. Fatima, hi, I'm in Northwest London doing the MSRA for CT, core medical training. That's interesting, for core medical training applications. Fantastic. So I suppose you've had a look at our situational judgment tests, which are free actually. So, I mean, I don't think the GP trainees need them, but if there's anybody preparing for GP entrance exam, then you need the situational judgment tests, and ours are free. So welcome, Fatima. Beatrice from Dorchester. Fatima from Newcastle, Friday from Grimsby. Fantastic. So quite a few people from up north at the moment. Fatima from Lancashire, Douglas from Kings Lynn. Parkleys Medical Practice. Parkleys Medical Practice. Who says Parkleys Medical Practice?
Parkleys is located near Springfield.
Is it the Dr. Briggs, or is it the Dr. Horn practice? I think it's that practice.
Jerry Horn, is it?
Yeah, I think so, yeah. Farshid from Rheal in North Wales. So my brother lives in Bangor, North Wales, and a lot of trekking in Mount Snowdon. So North Wales is a beautiful part of the world. So welcome from North Wales. A duo. It's one for you, Dr. Mo. Hi, Mo. How are you? He's asking for your flashcards. He hasn't. Please do you. He's asking when he'll get his flashcards. So I think he's asking for you there, Mo. Fatima, GPST2 doing AKT in April 21. Fantastic. So you've got lots of time to prepare for the AKT exam. Remember, we've got a free AKT question bank. So use that for your revision. We are updating it because there's been some nice guidance updates. For example, acute prostatitis, you probably may not have realized, but ciprofloxacin used to be given for 28 days. NICE has made a subtle change. It's now for 14 days. So we're updating our question bank. So keep up to speed with the latest NICE guidance changes, all part of the free AKT question bank for My Medics. So welcome, Fatima. Welcome, Hiba. Hiba from Egypt. That's fantastic. So Hiba from Egypt, pediatrician applying for an ST post. Mujahid from Wigan. So again, up north. Last few shout outs. I know Dr. Mo's about to get ready. Who else have we got? We've got quite a few people joining. Everybody, so it's really, it is Dr. Horn, so Jerry Horn Surgery, Kersley. So I was at Kersley last Saturday. I did an extended hours shift there, and I think Dr. Mo's worked at the Kersley Medical Centre. It's a very nice practice, very clean. Lally says, hi, Dr. Mo. Hi, Dr. Sandy. It's Dr. Sandy, but Sandy does sound good. so I'll take that. Delapo from Reading, welcome Delapo. Shaheen from the Isle of Man. Oh, fantastic, great part of the world. Ola Leakin joining us from Scotland, fantastic. So everywhere across the United Kingdom today. So brilliant, fantastic. Okay, so let's get started. So Dr. Mo is going to make, I know there's lots more people joining us now, but what we'll do is we'll probably make a start. So we've got 47 participants now. I know there's 126 or 128, I think, that have signed up. So we will leave it running, but Dr. Mo, I'll let you go. I think it's streaming live now to the iMedics.
Let me double check. Is it streaming? Is it?
Let me just double check for you. So just to make sure everything's okay. Let's do a refresh screen. No, it's not. It's not live streaming in there.
Fine. It should be in the next 10 seconds. Then I had to click a button.
Okey-dokey.
Right, guys, we get started literally in the next 30 seconds or so. This live streaming it straight into the Facebook AKT group and the RCA group as well. We appreciate some of you are joining us for the MSRA component of the exam that you guys are going to be sitting. And so the information is going to be relevant, especially with regards to the clinical side. We may do a later webinar on the MSRA, specifically about SJTs, but this part will be about the clinical part, which is why it's going to be useful for the MSRA. So just going to do a screen share so that everybody can see what I can see.
Yeah. Okay, Mo, so just to let you know, so it's now live streaming to Facebook. And if you are joining us from the Facebook group, just to let you know that if you do have any questions, you can just type it into the Facebook box. We'll keep an eye on it. Obviously, the majority of you guys, lots of people still joining us on Zoom, so you guys can use the Zoom chat or the Q&A feature. Okay, Mo, over to you then.
And you can see the whole screen, Bikash, yeah? Yeah, good. So guys, welcome to this AKT/RCA. We've also tagged on the MSRA doctors as well into this webinar. And the reason is because the clinical component of the MSRA exam will be relevant to the teaching that we're going to do today in today's webinar. So most of you would have joined us before, but if you're new to the setup with iMedics, basically we cover 2 topics. We get you to learn at least 3 key learning points for each topic. These are like high yield learning points that are most likely to come up in the exam or most likely to come up in an RCA type setting. And so the 2 topics today are going to be croup and smoking cessation. Smoking cessation is like super common. You should generally do it whenever you get an opportunity. And therefore, Dr. Sanders is going to talk about that in depth a bit later on. So let's get to give you an outline. We're going to cover the first part of the webinar to do with croup. So we're going to cover the latest guidelines from NICE, and then we'll take questions and answers. Should be relatively straightforward. Croup is generally a straightforward topic, and I appreciate before we had topics like menopause, which can be quite tricky. We'll talk a bit about a couple of promotions we've got on the website, which are going to be relevant for your studies and your exams. And then we're going to move on to smoking cessation. And again, there'll be an opportunity to ask questions. So you can type them. There's a Q&A button at the bottom of Zoom. If you press that Q&A button, you can type in your question and we'll come up to the questions right at the end if that's okay with everybody. So once again, thank you for joining us. It is a Sunday evening. It's relatively late, but we'd hope that it's going to be convenient for you all. So let's start off with a recap of croup and then we'll come on to the learning points. And as I mentioned, my style tends to be 3 key learning points. And the reason for that is to try and keep it easy to understand and easy to remember, of course. So croup is a viral infection. It's a viral upper respiratory tract infection, commonly found in children, usually between the ages of about 6 months to 6 years. But of course, you can get it in an older demographic, but that's the most common age profile. And the key characteristic of croup is obviously the seal-like barking cough. If you've heard of it, if you've heard it before, which you should have, or you may have come across it during a pediatric rotation or in a GP clinic, it's a very distinctive cough. And it's important that when you take a history from a parent, that you're able to ask them what kind of cough is this? Does it have like a barking effect or a barking sound to it? And most parents will be able to say yes, it sounds like a seal-like bark. Now, it's important to know that there can be associated symptoms. So this is the recap, guys. This is stuff you should already know. There can be associated symptoms that are commonly found with croup infections. So usually a hoarse voice is relatively common. Stridor is also common as well. So stridor is an inspiratory sound that's made. It's due to airway obstruction. And it's a very classical sound. So if you Google stridor, you'll be able to listen to it, or you must have come across it, of course, before in a clinical setting. And then you can get red flags associated with presentation of croup respiratory distress. So that could be, for example, sternal recession, intercostal muscle recession, usage of muscles in the abdomen to try and obviously pull the diaphragm down. Those are all related to respiratory distress, and we'll come on to that in a short while. The other key thing to remember, and again, this is a recap, is that croup is often preceded by upper respiratory tract type symptoms, which can include a fever, a runny nose, and also a cough. So you don't always get the barking cough straight away. That can be 24, 48 hours later. You can initially get, for example, temperatures and a runny nose to begin with, and then you get the classical symptoms later. So this is a recap. Let's move on to the key learning points. So NICE effectively break down croup into, well, they break it down into 4 categories. The 4th category I'll move on into a short while, but the 3 main categories, which you'll see most commonly in a clinical setting or an exam setting, will be mild, moderate, and severe croup. So with mild croup, you get a seal-like bark, which is the cough, but then you don't get any additional symptoms. You don't get stridor, sternal recession, respiratory depression, or respiratory distress of any sort. With moderate croup, you get a seal-like bark, but you also start to experience that this patient also starts to experience stridor, will have stridor symptoms, and they'll also have sternal recession, plus or minus sternal recession. And therefore, if you see a patient with a seal-like bark and they've got stridor symptoms or they've got sternal recession associated with it, you can comfortably diagnose them with moderate croup. Towards the severe end of the spectrum, children will start having agitation and lethargy. So they'll seem agitated or they'll start to become very lethargic, and they may also develop intercostal recession at the same time. So that's not necessary to diagnose severe croup, but it can or cannot be present at that point. The key diagnostic parameter there is agitation or lethargy. There is a 4th classification for croup, and that's impending respiratory failure. Hopefully none of you ever see this, because obviously we don't ever want to see a child reaching that stage in the illness, but it's something to be aware of, that it is an additional classification according to NICE. So the four classifications are mild croup, moderate croup, severe croup, and of course impending respiratory failure. Now, why is this important? The reason this is important because the classification of croup will determine your management. And I've broken it down into a green color and a red color for ease of learning and memory, of course. If you have a patient with a child with mild croup, so just a seal-like bark with no red flags, and the observations are relatively normal, then essentially you can treat them in the community. And I'll come on to the more definitive management in the next 2 slides. If, however, the patient and or the child is exhibiting moderate to severe elements of croup in terms of the classification, really what you're doing at that point is you're admitting the patient to a PEDS unit, to PEDS A&E, or to the hospital effectively. And what's going to make the difference there is if they have stridor and sternal recession, or agitation and lethargy, or intercostal recession. So the management's really straightforward. If it's mild, treat them in the community. Anything more than mild, they get admitted to hospital. In terms of impending respiratory failure, so this is the 4th classification according to NICE of croup, and you could call it the more severe end of the spectrum. And there are a couple of things you want to watch out for here. So if, of course, the child has sternal recession, or intercostal recession, but it's increasing over time. So again, it's getting worse and worse over time. If they have asynchronous chest wall movements in comparison to the abdomen. So the example is obviously when a child breathes in, or whenever someone breathes in, the abdomen tends to, the abdominal muscles tend to contract and go inwards as the chest expands. So if you do that yourself at home, if you breathe in, take a nice deep breath in, the abdominal muscles will go inwards, whereas the chest wall muscles will tend to go, and the chest wall itself will go outwards. In impending respiratory failure, the opposite happens. So whilst the chest wall goes outwards, the abdomen may also go outwards at the same time. There's a mismatch between the two, and they're not in synchrony effectively. And if that is happening, that's a red flag, and it indicates impending respiratory failure. The other thing to be aware of is these are general pediatric observations, which would indicate red flags. It would be fatigue, so the child extremely tired. They're starting to build up the lactic acid, of course, in their blood. If they're starting to develop cyanosis, whether it's central or peripheral, or they have pallor, if they're starting to exhibit decreased levels of consciousness, If their heart rates, remember in pediatric patients, vital observations are age specific. So be familiar with the age specific normal parameters for vital observations. If you've ordered our flashcards, which are free on the website, you only pay for postage and packaging, you'll get the age specific vital observations, which you can carry around in your wallet or your card holder at work, which is really, really useful. And then of course, the other thing that NICE highlights is if the respiratory rate is over 70 breaths per minute, which is fairly high, even if you correct for certain ages within pediatrics, that indicates impending respiratory failure. So that's a bit about the classification. That's the first and second key learning points, what the classifications are and how you manage. So mild, community, anything above mild goes straight into hospital. The second key learning point is how you actually manage the child themselves. So there's essentially a breakdown into two categories here. Again, one community management and one admission management. So if you're going to manage a child in the community, they've got mild croup, you can treat them with oral dexamethasone, and the dosage here is 0.15 milligrams per kilogram. So what you may get in the AKT exam, for example, is a calculation question to do with this, or the MSRA exam, you can get a calculation question. The child weighs 15 kgs. How much oral dexamethasone dosage do you need to give that child? The 15 times 0.15, and then that would give you the answer. Remember, sometimes it can be a bit tricky. If the child's heavier, 20, 30, 40 kilograms, you may want to then move away from milligrams. So if the dosage is much higher and you start to move into the gram area, it shouldn't occur obviously with children, but sometimes it does in calculations. Just be wary of milligrams, micrograms, and grams, and the transition between the three when you're moving up in terms of the size of the dose. So when you're moving to a large dose of milligrams, let's say 500 milligrams to 1,000 milligrams, you may want to convert that to a gram dosage and write it down as a gram dosage in real life, for example. In terms of admission itself, if you're admitting a child who obviously has been diagnosed with moderate, severe, or impending respiratory failure, you should treat them whilst you're waiting for the ambulance to arrive, or treat them before they're sent on their way to the hospital. And NICE recommend 3 separate ways of treating moderate, severe, or impending respiratory failure type croup. That would be with oral dexamethasone. You can also treat with inhaled budesonide or intramuscular dexamethasone. Obviously, the route of treatment depends on how unwell the child is. If they're struggling to swallow because they're having to focus on their breathing, then you would perhaps give them an inhaled budesonide or an intramuscular dexamethasone as a route of treatment. The doses are listed there. So with inhaled budesonide, it will be 2 milligrams as a nebulizer as a single dose. And with intramuscular dexamethasone, the dosage varies. It's 0.6 milligrams per kilogram as a single dose. Now, of course, if you have a child who's having impending respiratory failure, you want to have all the team alerted. So yeah, there's a little red button in, for example, the EMA software, which you double click so that the team are aware that there is a medical emergency in the building, that the ambulance is called. And if the child does then go into a respiratory arrest, which is usually the most common thing in children, that you start the appropriate CPR. And of course, a defib needs to be on hand in case, again, the child goes into cardiac arrest. But these are all important things to bear in mind as you're progressing through certain cases when you see them face to face in real life. So this is the management in terms of how you approach management. And of course, remember that it depends on the classification. So the last thing to be aware of is safety netting for croup. So most of the time when parents come to see you with a child who has croup, especially if it's mild croup, you need to emphasize that the condition itself is self-limiting. I mean, we're getting into the winter months now, so it's going to be more and more common as a presentation. Most of the time, the condition is self-limiting. There's no need for antibiotics. It will usually resolve within 48 hours of onset. And most of the time, it's about managing the pain or the fever symptoms. And you can, of course, signpost ibuprofen or paracetamol. However, the key thing with the safety net is if there is any significant change, or if there's any change whatsoever in the presentation or any deterioration, that the parents need to seek urgent medical advice, because obviously croup can transition between mild, moderate, severe, and of course life-threatening. And so a tight safety net explaining what things to watch out for, what things to be aware of, is always very important. And of course, don't forget to signpost about a non-blanching rash, which can sometimes indicate, for example, meningitis. Why would it be relevant? Well, if you have a feverish child, they may go on to develop a rash, and that's always something worth mentioning to parents and as well as the glass test if you feel like that's appropriate at that point in time. So the 3 key learning points from the Croup side of things were, firstly, there was a recap in terms of how you diagnose. Secondly, the classifications, mild, moderate, severe, and effectively life-threatening, but NICE says is called impending respiratory failure. Fourth, how you manage based on the classification. So anything that isn't mild goes into hospital. It's treated in a hospital setting under the pediatric team. But anything that is mild, so only sea-like bark with no red flags and the vital observations are normal, you can treat in the community. If you do treat in the community, it's important to obviously go ahead and you can prescribe steroids, oral dexamethasone as a single dose, 0.15 milligrams per kilogram. Make sure you get the calculation right, of course. And then from there, it's a case of safety netting, reassuring the parents it will settle. And of course, if there's any problems, to get them to call you back. So that is, in a nutshell, the Croup topic today. I know it's been relatively brief. We appreciate that. Some of the other topics tend to be a bit more meaty, especially like topics like menopause or asthma management, where there's like step 4, 5, 6, 7 in the algorithm. But we're doing lots of different topics throughout the year, so it's important that we chose topics that are relevant to the time of the year that we're in. So what we're going to do now, guys, is we're going to give you an opportunity to ask any questions that you may have. We're also going to do a quick screen share so that you can see some of the promotions we have on offer in the next 24 to 48 hours. Let me just jump out of the presentation for a second and do another screen share for you. And then if you have any questions, there's a Q&A button down at the bottom, which of course you can press on and then enter any questions. So quick show of hands, how many people are sitting the RCA exam in the next 3 to 6 months? There's a raise hand button on Zoom. If you just don't mind quickly raising your hands, 5, 6, 7, 8, 9, 10, 11. So quite a few, 12, 13. So quite a few of you are going to be sitting the, so if you lower your hands, if you don't mind, VCAS from your side, you should be able to lower their hands, I think. So for those of you who are sitting the RCA exam, we're doing an advanced communication skills course, which is done on Zoom. It's a full day course, only focusing on advanced communication skills, stuff like bridging the gap, appropriately signposting, how to manage ethical cases, how to demonstrate a good management plan, how to demonstrate a shared management plan. We've got an amazing price on. We normally have this priced at $79.99. Currently, it's priced at $49.99 with a limited time sale price. Guys, this would be one of this has so much information in it. This has an unbelievable amount of information in it. It starts at 10 and it finishes at 5 p.m. And me and Dr. Sandhu go through a variety of different cases that you'll come across in the RCA that you can record and obviously submit to the Royal College. Highly recommended. Probably one of the best value courses out there. So it's really a no-brainer at $49.99. And there's a choice of dates. So it's 3rd of January, 14th of February, 28th of March, and you can do it from home effectively. So if there's one thing that you do today and you're about to sit the RCA exam, I would subscribe to this advanced communication skills course. It's packed with information. Like we've spent a lot of time making sure that it's got everything in it. So you pretty much get all the information that you need to the theory on advanced communication skills, but also how you implement those advanced communication skills into real life. And then we do live demos. And the actual day we do live demos so you can see for yourself. So without a shadow of doubt, guys, this would probably be the best $49.99 you've ever spent. I'd highly recommend it. And this so you just need to click on it, add to cart, and then you can check out from there. For those, quick show of hands, who's going to be sitting the AKT exam in the next 3 to 4 months? Quick show of hands. Just raise your hands at the button, which allows you to raise your hands. 3, 4, 5, 6, 7, 8 people, 9 people, 10 people. Okay, 11. For those, 11, 12. For those, so you can lower your hands. Guys, for those of you who are going to sit the AKT exam in the next 3 to 4 months, the AKT Big Mock. I know a few other companies do it, but we've priced it extremely competitively at $99.99, under £100. It's a full day. It's a full day teaching as well as mock exam. So you do 3 hours mock to begin with, and then we do 6 hours of teaching, which go into the NICE guidelines relevant to what's going to come up in the exam. These are the latest NICE guidelines. If you've already joined our free AKT question bank, you'll know the quality of information we include, and we just summarize that, we condense it down, and we put it into this mega mock exam where you can learn so much from the exam questions themselves, but also appreciate what's most likely to come up. So we use the feedback from previous exams. There's 2 dates at the moment, January and April, depending on which sitting you have. And again, guys, it's a limited time sale price discount at the moment at $99.99. Highly recommended. It's like excellent value for money, and you will learn so much. It'd be like one of the best teaching days you will have when you come to this course, based on the feedback we've had from previous VTS trainees who've already sat the AKT Big Mock. So those two I'd highly recommend, guys. Just do it today. I'd get yourself booked in, so obviously you've got it in your calendar and you can move on from there. So Vikas, what I'm going to do is I'm just going to transition over to any questions we may have. We've got, okay, so Mujahid's got a good question. If we don't have Dexa, then can prednisolone be given? The short answer is it can, and you normally prescribe at a dose of 1 milligram per kilogram. That's the standard dose for prednisolone. But don't go above a dose of 40 milligrams. Usually cap it at 40 milligrams. Sure, Dr. Sandhu will agree on this. If you are given prednisolone, don't go over a certain dose. So most kids are relatively light in terms of their weights. So if they weigh 10 kilograms, the dosage would usually be 1 milligram per kilogram. Because if you don't mind double checking that dosage, the last time I checked it, it has been 1 milligram per kilogram, because the Dexa dose obviously is different, because obviously it's a different type of steroid chemically. And then the second question we have is, can we have one more RCA Advanced Communication Skill course in December as well? Guys, we've got a jam-packed schedule in December. Me and Dr. Sandhu will have a chat. We'll try and get that scheduled for December if possible. But if not, then obviously there's other dates available, because I appreciate some of you have got RCA assessments to submit very, very soon. So I hope that answers the question. Vikas, did you double check the prednisolone dose? If you just unmute your mic then.
So I'm just doing a quick search for you. So if you go into CKS, it's not very clear. So let's have a look. So you've got, oh, there we go. So the oral dexamethasone is 0.15 milligram per kilogram, obviously in children. For prednisolone, it doesn't specifically say. So you'd go with the BNF doses by the looks of things. So they've given you the dose for dexamethasone, which is 0.15 milligram per kilogram, whereas the prednisolone is not mentioned in there.
Yeah, I think someone's double checked it. It's between 1 to 2 milligrams. That's what I remember from prescribing it a short while ago.
Yeah, so that's the BNF would be 1 to 2 milligram per kilogram.
Remembering from what we did in our pediatric rotations, it was 1 milligram per kilogram from the top of my head, and they would cap
make sense. Yeah,
they would cap it between 40 to 60, so you don't give them too big a dose.
Yeah.
Obviously, children are relatively light. Adeniki's got a good comment, Vikas. The AKT date is too close to the April AKT exam. Can it be done earlier? We'll have a chat. It's unlikely that we'll change it, but we might pull it back a little bit, so you've got a bit of breathing space between the actual exam and the mock exam. Really, the mock exam is about boosting your score. So you learn all that information as close as you can to the exam, and then you sit the exam and you work on your weak topics, like in that 7-day gap. It's unlikely that we'll change it. And Friday, thank you for that comment. You've transitioned from P's to GP land. Yeah, we both did. Actually, me and Dr. Sandhu both met on a P's board. Is how we first met. So okay, Vikas, what we'll do, I'll hand it over to you. Allow you to share the screen. We'll move on to the next topic.
Perfect. So I'm just going to take it to the beginning. So perfect. So let's get the screen loaded up. So guys, the second stage then of your kind of 2 weekly AKT/RCA preparation webinar is going to focus on the topic of smoking cessation. So it's relevant to both. So you can get questions in the AKT on it. And we've also got an RCA slant on it, so that we cover both bases. And of course, it's good theory revision. So all from the current NICE guidance. It's a good update on what smoking cessation is. And what we're going to do, so obviously a brief definition. You probably have got used to my style of teaching now. So brief definition of what smoking cessation is. A couple of things to think about when you're doing your histories for your RCA exam. Of course, it was CSA, but for the time being, it will be the RCA. And of course, an overview of the current treatment options that we have when we're talking about smoking cessation. So we need to define it first. So it's essentially just a range of different things that we can offer to try and support someone who's trying to stop smoking. So that's a brief definition of smoking cessation. Quite as a common topic and something which you do see regularly in your practice. History taking. So what should we do? So now when you speak, you've been exposed to lots of people who smoke, whether you've done a respiratory job or an A&E job. And of course, in GP land, we see lots of people who smoke regularly. The current evidence actually says that you don't really want to pepper them and pester them into stop smoking, because actually they're unlikely to do it. They're more likely to comply if we just ask them opportunistically, Mrs. Smith, by the way, do you smoke at all? And if she says, oh, yes, I do, yeah, okay, and how many do you smoke a day? And how long have you smoked for? And have you thought about stopping? And that's the only thing you need to ask. So have you thought about stopping before? Now, they might turn around and say, yes, I have, or no, I've got no interest in stopping, doctor. Now, if they say, I've got no interest in stopping, doctor, the nice guidance says, okay, leave it there. You don't have to then, force them or what have you. You park it there, and you can revisit that when they see you again, or when they see the nurse and so forth. And even if they see a pharmacist, so all healthcare professionals should just do what we call very brief advice, which is, do you smoke? Have you thought about stopping? Now, lots of people will have thought about stopping. And so if they have, you can say, well, have you tried to stop smoking before? What did you try last time, Mrs. Smith? And how did you get on? How long did you stop smoking for? And what made you go back? And these are things that you can then tailor your management towards. So if they say, well, look, I did stop. I stopped for 3 weeks. The craving was too much. I'm a big football fan. I used to get together with all my friends and they all smoke. And therefore now there's a pattern of behavior that you need to try and change. Otherwise, it's going to be very difficult for you to try and get this person to stop smoking, but we can utilize that to our advantage. Their social history is very important. Are there other smokers at home? What do they do for a living? So people often smoke when they're at work, and they often go on a smoke break together. And sometimes that's the type of coping mechanism that smokers have. And what do they do for recreation? So, what like I said, they may watch football, they may go to clubs and bars and various other things, and they have these kind of recreational activities that they do in their spare time. And therefore, we need to try and focus on how can we utilize that and reduce their likelihood of increase their chances of stopping smoking. So it's important that you have a think about these things when you're doing your history from an RCA perspective. Obviously, smoking cessation is a big topic. There's lots of different things that we need to think about. In terms of as doctors, it's interesting because the amount of management that we do for smoking cessation has declined. And actually, we're probably more likely to do the history and then refer them to the smoking cessation clinic, which your surgeries will all have. And you normally have a nurse who's trained in smoking cessation, and he or she will be the one who will, administer the treatment and do the monitoring from that point onwards. But, and it's interesting because when I was a registrar, I used to think, well, actually, this patient's told me she wants to stop smoking. Why can't I just start the treatment today? Because that will be so much easier, right? And then actually it was the practice nurse who told me, well, it's not easy to do that because once you've seen them, you might not see them again. And we measure their carbon monoxide level, which is a good objective marker. And we do it each time they come in so that we can actually show them that, look, your markers were really high. And now we're starting to bring those levels down and your treatment is working. So that's the kind of the reason why it's kind of moved now more to a nurse-led service. But of course, you still need to know it. It's still a topic that can crop up in your RCA and of course tested in your AKT exams as well. So what do we need to know? Well, the first thing is you've got high-risk groups. These people should not be smoking at all. So pregnant women, mothers who are mothers of children who are very young, especially those who are breastfeeding, and also young people aged between 12 and 17. So now, obviously, we know that the obvious reason for this, obviously, if you're pregnant, you're more likely to have comorbidities and issues arise during the pregnancy, like preeclampsia. There's a risk of obviously abnormalities to the fetus as well. So there's huge things that we have to think about. Young people, it's interesting because what the theory here is that the younger they are when they start smoking, the more likely they are to adapt to that behavior and it becomes part of their normal behavior. They get addicted to the nicotine and they're likely to then follow that through into adulthood as well. And of course, the younger you start, the more damage you do to your lungs, and therefore the more likely that they are to have problems like COPD, increased risk of lung cancer, and of course a whole range of different diseases that you get from regular smoking. So what options do we have? So obviously you've got your stop smoking services. These are mostly done in the GP surgeries, but you will find lots of pharmacists, for example, locally that will have a stop smoking service that's available. Of course, they'll be available in the hospitals as well. The key trick, like I said, is the fingertip blood test for the poisonous gas carbon monoxide, which is that CO, and that's what they test and they monitor it. They also offer practical advice, so the nurses will take a full history in terms of what do you normally do in your spare time. Talk me through it, you know, and then we focus on things that they can do. Now, the practical advice is interesting because people who are trying to give up smoking have a habit, and that habit is when they're stressed, they pick up a cigarette. When they're at work and they're on the break, they have a cigarette. When they have a coffee, they have a cigarette. They start to build these patterns and their brain starts to have this cognitive process where it automatically starts to kind of think of a cigarette in different situations. So the theory is you teach them new things. Say, listen, have you thought about, you know, going for a walk or jogging or badminton or, you know, going to watch a movie? Tell me what kind of things you enjoy. You know, what does your partner enjoy? What do your kids enjoy? And how they can incorporate that into their lifestyle. There is a good app. There's a smoke-free app, and I think it's sensible if you're doing the RCA exam. Examiners, and we always, as me and Dr. Mo have said before, when we teach our students, we normally go into the CSA mode. So examiners love it when GP registrars can actually specifically name something rather than, yeah, there's a range of different apps you can try. If you say, oh, by the way, Mrs. Smith, have you heard of the smoke-free app? No, I've not heard of that before. Okay, well, it's an interesting app devised by the NHS. It's got lots of practical guidance on how you can stop smoking, lots of behavioral advice, lots of support that you can access on there. How would you feel about giving that a go if I gave you the details today? So you can see that you're coming up with a shared management plan and you're actually quoting a specific and licensed app that's becoming quite popular. Now, normally they say you should stop abruptly. And this is interesting because there's a subtle difference. When you start, if you see the patient, you can actually say, look, have you got a target stop date? When do you want to stop? Well, doctor, I'd like to stop, you know, in 3 weeks. Okay, well, let's stick with that date. What's the date in 3 weeks? It might be January the 1st. Right, let's put January the 1st down as your target stop date. So again, the reason behind that, again, is if you have blurred boundaries, the patient's probably not going to stop because it's a really, really addictive habit that they're trying to break. The three main treatment options that we should know of course, we've got nicotine replacement therapy, and we've got our two main medications, varenicline and bupropion. Now, remember, you can give varenicline or you can give it a combination of nicotine replacement therapy. So there's things like patches. And what they've found is that if you give a combination of nicotine replacement therapy, it's most likely to be more effective than if you just give one form of nicotine replacement therapy on its own. We then follow them up, or the nurse rather follows them up 2 weeks after they've stopped smoking. And then after 4 weeks, they measure the carbon monoxide level. And then after that, they continue to have follow-up until the patient feels kind of stable, happy, that the levels are falling, and they feel comfortable that, look, I'm okay now. I feel like I've got through, the treatment's worked, and I'm happy to kind of, you know, be discharged from the clinic. In terms of nicotine replacement therapy, remember, you've got lots of different things. You've got lozenges, you've got patches, you've got lots of different kind of methods, inhalers now as well that they offer. The key thing is if you use patches, the long-acting patches, they tend to give a steady release of nicotine, whereas the fast-acting forms of the nicotine replacement therapy are good for the immediate kind of cravings that people have. And that's where the combination theory comes in to make sure that it's more effective. The patches are normally put on for 16 hours. It's important that we know this kind of information in case your patient says, okay, well, doctor, you're telling me about these patches. How long should I wear them for? Well, we know now because the CKS guidance tells us, apply it for 16 hours, take them off overnight, unless you've got a 24-hour patch. And that will say on the box that this is a 24-hour nicotine replacement patch. And the 24-hour patch is often given to those people who like to have a cigarette first thing in the morning. And that's a perfect example of how addictive this habit is. People will actually wake up and the first thing they do, some of you are probably thinking about breakfast and coffee and tea and brushing your teeth. A strongly addicted cigarette smoker will actually want to have a cigarette. Remember we said before, so combination of nicotine replacement is effective. And it's said to be the most effective rather than just using one form of nicotine replacement therapy, as well as it's a patch or a lozenge or gum. And lots of these things you can actually get over the counter as well. The two medications that I mentioned, so just a couple of learning points to take away for you guys. So varenicline, we normally tell them obviously what the dose is, that the treatment is normally going to last 12 weeks. So it's important that patients are aware that it is a 3-month course, and you normally need to start it 7 to 14 days before that target quit date. So, you know, that's why you pencil in that date. What date do you want to stop on, Mrs. Smith? Okay, great. Well, what we normally do is we start you on a drug called varenicline, and that's helps reduce the cravings that you get from the addiction that you've had for so many years. We normally start it 7 to 14 days before your target quit date. The other thing to counsel them about is that you can, in rare cases, get severe mental health like psychosis, severe low mood, depression, and nightmares. If that happens, they obviously need to get back in touch, and then NICE recommends that we stop this drug. It's a very rare side effect, but it's something to be mindful of. And it is contraindicated in people under the age of 18, which again is important for you to know because lots of teenagers now smoke. And of course, if the patient's got end-stage renal failure. Your other medication is bupropion, same thing. So, you know, it's a medication that, again, you've got your target stop date. You want to start, it needs to be started at least 7 to 14 days before that target stop date. But the only subtle difference is the treatment ranges from about 7 to 9 weeks. So it's not 12 weeks like varenicline, it's 7 to 9 weeks like as it is here. It's an important distinction for your RCA and also for the AKT exam. And the AKT, and specifically for the AKT, but also if you've got an RCA patient who's got, for example, a history of epilepsy, then you need to know that there's some certain contraindications, so things where we can't give this drug. If the patient's got a documented history of seizures like an epilepsy, they can't have the drug. A central nervous system tumor, currently or previously being diagnosed with bulimia or anorexia, or a history of bipolar disorder or severe hepatic cirrhosis. So these are important things to be mindful of, because we often do see patients with bipolar or, you know, bulimia or anorexia or indeed seizures. You may not see severe cirrhosis or central nervous system tumors that much, but it's important that you're aware of these contraindications. The carbon monoxide level, remember, we measure it after 4 weeks after the patient stops smoking, and a level of 10 or less than that suggests that the person is now in the non-smoker territory. So that's a positive sign. It's a positive reinforcement. And like everybody in life, if you've got a objective marker, it's a lot better because you can prove to them that, look, this is the poisonous gas that was going to damage your blood, damage your heart, damage your lung, damage your brain, put you at risk of, you know, lung problems, strokes, heart attacks. And now we've dropped it from what it was before to, you know, 9 or 8. We're going in the right direction. That's a good objective marker. What about e-cigarettes? So e-cigarettes are a hot topic. So you probably have seen them, vaping, people call it. Lots of people do use e-cigarettes now, and sometimes people believe that it's better for them rather than smoking. Yeah, so people think it's better for them than smoking. So key thing, so if people are using e-cigarettes, we should still refer them to the Stop Smoking Service. So we shouldn't think, okay, well, he or she's on an e-cigarette, they don't need to be referred. Still offer them that. E-cigarettes are relatively new, so there's not enough research done on their long-term risks versus benefits. Some patients may say, well, look, doctor, it's got less nicotine in, so can I have it on prescription? And the answer to that is no, because they're not prescribed on the NHS. But NICE CKS, and I pasted this quote from the CKS because it's interesting, and they said, consider suggesting e-cigarettes as a way of stopping smoking to people who've tried unsuccessfully to stop in the past using other methods, but you should use your clinical judgment and judge each case on an individual basis. So e-cigarettes should not be your first port of call, but if you've got someone who's had numerous attempts, they've tried the nicotine replacement and the medication, then we can try and say, okay, look, try the e-cigarettes first. There's less nicotine in there. Hopefully we can wean it down, and then we can try you back on the treatment methods that we mentioned earlier on. And then obviously you will get some patients, they will say to you, look, doctor, I'm not ready to stop smoking. And this does happen. You know, many of you, I'm sure most of you as GP registrars will have had this on numerous occasions, and it may happen to you in clinic. And so NICE basically says, that's fine. you know, we can't force people to stop smoking. You should then focus on something called harm reduction. So harm reduction is to kind of make the patient aware of what they're doing is obviously detrimental to their health. Just plant the seed. So let them know that, look, that's absolutely fine, Mrs. Smith, but if you do decide to stop smoking, we have got a fantastic stop smoking service. So you've planted that seed. You can also still say, well, look, you know, have you thought about cutting down? Maybe, you know, if you have 10 cigarettes a day, how about you try 8 for a week and then up to 6 and then to 4, see how that feels. That's an option. You know, smoking reduction with or without nicotine replacement therapy, temporary abstinence as well. So just saying, listen, for the next week, I'm not going to smoke as a sort of like a sort of fasting type thing. And of course, you know, nicotine replacement may be used as well to try and help with this harm reduction process. So there's just a few strategies that NICE suggests that we should offer our patients. Pregnancy and breastfeeding, so important to be mindful that pregnancy and breastfeeding, we mentioned it before, they shouldn't be smoking full stop. But if they are, they need to be obviously referred for practical advice to the Stop Smoking Clinic, obviously weighing up the risks and the pros versus the cons. But the important thing is that the varenicline and bupropion are not to be prescribed in pregnant or breastfeeding women or young people under 18. So that's an important take-home message. If the woman is pregnant, and this is a common AKT topic, then she should be offered nicotine replacement therapy, and of course a strong discussion about the dangers of smoking to both her health and of course of the baby as well. So we're on to questions. And a quick signpost to our social media while your questions do come up. So if you haven't done so already, you should be aware that iMedics are on social media. We've got lots of fantastic revision. Our Instagram page, inspire_medics, will have learning cards and videos and revision that we put on and some motivational quotes. The Facebook link, which I think Dr. Mo will add in to the Zoom chat now, is an AKT and RCA preparation group where you can use it for your learning, as well as the fact that we post videos and revision cards for both exams. The YouTube Inspire Medics page is also very good. Lots of insightful revision videos based on the current NICE guidance. And of course, we've got Twitter as well, Inspire_Medics latest revision, as well as medical news and updates and exam updates and so forth across the UK. So that brings us to an end. Questions? Oh, I thought there was quite a lot, but they seem to have gone.
I think there's a couple of general questions. I think we're getting a few comments that the RCA course may be a bit too close to the submission date, which makes sense. We haven't got one that's going to run in December, so we could potentially pull that back VCAS a little bit. But yeah, we've got already quite a few people booked onto it, so we'll have a chat we'll have a chat, me and Dr. Sandhu later on. We'll see what we can do for that. But if you provisionally book on it for now, it's still a really good learning day for those who are sitting the RCA exam. So I don't think we've got. So okay, you're right. So in the MSRA exam, you will get your knowledge base tested on clinical sciences, which includes smoking cessation and Croup. Let's see, is there anything else? Okay, good. So I don't think there's any other questions. I'm just going to do a quick screen share because there is one other thing we'd like to share with you guys, and it's the Medic Flow platform, which is a WhatsApp platform to connect junior doctors like yourselves who are either working in hospitals or working in GP surgeries. Basically what we do is we get all the GP surgeries in an area, let's say in Coventry, we add them into the WhatsApp group, and then you can join the WhatsApp group. And let's say you're a fully qualified GP, you'll find that all those GP surgeries in Coventry post into the WhatsApp group their jobs that they need covering for locum shifts, and you can then communicate with them directly rather than having to call over 30, 40 different surgeries and email them or text them all the time. You can do it within WhatsApp. And then similarly for hospitals, if you do locum shifts in hospitals, every now and again, we've got locum WhatsApp groups, locum hospital doctors WhatsApp groups for each CCG. So if you're working, let's say Birmingham and Solihull, there'll be a group for that for hospital doctors, and literally all the hospitals in the areas will post their locum shifts into it, and then you can just communicate directly to the hospital rota staff. It's completely free to use, doesn't cost anything. We don't charge you anything. So it's a really nice way of networking, something to be aware of. And if you're interested, just drop a message on WhatsApp to this number. It's +44 756 101 4363. Guys, if you write it down now, punch it into your phones and send us a quick WhatsApp if you're interested in being added. We've got a separate group for each CCG. We've got separate groups for hospital doctors and GP doctors. So the WhatsApp number is +44 756 101 4363. Drop us a WhatsApp right now. Literally take you 30 seconds and say what your name is, what your job title is, so hospital doctor or GP doctor, and which CCG you want to be a part of, and then you can be added to the group. It could be, you can be in our group, for example, 3, 4, 6 months down the line when you become a fully qualified GP. We'll have your details and you'll be active in the group at that point. So it's a really easy way of connecting with GP surgeries and hospitals as well. So I'm just going to stop there. We may have 1 or 2 questions. Oh, I think that was your chat, Vikas. Okay, guys.
One more thing. So we haven't shown them the blogs. So give me 1 second. I'm gonna. Okay, so basically, guys, just one more thing, just to quickly show you all your revision. So basically, if you go onto the iMedics website, you can see, obviously you can see it here, but if you click to blogs, you've got doctor blogs, patient blogs, and iMedics blogs. So if I click, say, the doctor blog, and let's say we want to do GP exams, MRC GP. So we'll click the MRC GP exams, and what will happen is you'll see a whole host of really good blogs that we've done, like, for example, let's say acute asthma in children, which our team has made for you guys. It's very good. It's very good for your revision. So it's free. It's on the website. You can kind of use it. It's easy to follow. Can you see it's kind of color coded? It's got all the key features. It's a great revision tool. It's going to be great for your kind of revision for AKT and for RCA and for your clinics in general. So do use it. So, you know, there's hundreds of articles now going up from our team. And there's lots and lots of taking a history, you know, adult stuff, so asthma in adults. And it's a nice blog. Again, the same kind of easy to follow format. Dealing with angry patients or relatives, delivering bad news. These are all relevant topics for everyone preparing for RCA. Menopause and HRT, great hot topic, things that we all find really difficult, you know, so have a look, have a read, obviously do share with your friends, let your deanery and VTS know as well. And this stuff is for you. So I think the one thing you guys probably have realized is that we're trying to make lots of cost-effective things for you guys. So utilize the stuff that we have. And if you've got any questions or anything, let us know. We have got another webinar at 8 o'clock for prospective medical school students. So basically, we'll leave this chat running for about 40 seconds. Just let us know how you found today, any feedback, anything you want to say to us before we leave you guys today. If there's any other topics you want, obviously just drop us a message. But yeah, let us know how you found today. We'll leave it running for the next 30 seconds or so. So Sajida said it was really good. I think Fatima, very helpful. Thank you very much. Perfect. Thank you, guys. Appreciate your kind comments. Just let us know, guys, how you found it today. I think there's still everyone's still logged in, which is great. So Ala Lekan, thank you so much. I think there's a message above from somebody as well that I've missed. Ajiman, thanks, guys. Ola Lucan, thank you very much, very helpful. Brian Richards, great, thank you. Fatima, really helpful, thanks a million. Thank you, Fatima. And Babitha, thank you very much. Beatrice, thanks, very helpful. Friday, very useful, thanks you to the iMedics team. Narendra, it's been very helpful, thank you both of you. Thank you, Narendra. Saida, thanks a lot. Sajida, perfect, thank you for the free blogs. Yeah, fantastic. So all of this stuff, remember, guys, is for you. So use it to your advantage, use it as much as you can. You know, everything we're trying to do is for you guys, really. So and if you've got friends who, you know, haven't seen what we're doing, signpost them. Use the free AKT bank as well. Remember, it's free, and it's got the gamified stuff as well, which is quite exciting. And of course, as Dr. Most suggested, I think you'll all be at different levels. I think there's some more comments coming through. So Shaheen, thank you, Dr. Mo and Dr. Sangdu. It's very helpful. Mujahid, thank you. Adeniki, thanks, really straight to the point and helpful. Nandan, thank you for the webinar. Dalopo, very helpful, thank you. Do we need to know doses of smoking cessation drugs? Probably not. it's not, it wouldn't do you harm to note them down, but really you wouldn't. And actually, because you're doing the RCA, you would actually now you'd just quote the BNF, so you'd have the BNF, and you wouldn't. Nobody can mark you down, remember, guys, for being safe. So as an examiner would say, yeah, this guy was sensible, he didn't know the dose, but he looked it up in the BNS and so forth. So not to worry about that. But perfect. Okay, guys, so we will leave you guys to it in that case. Keep up to date. Thanks for your help. Very useful and economical. No, that's a very good point, Ray. And that's what we're trying to get across here. And I'm going to capture that. The reason, so Ray's written, thank you for your help. Very useful and economical. Others are charging £450 for a similar RCA course. Now, that's the thing that we're trying to get across to you guys, that we think what we offer is a fantastic service. You shouldn't be paying over the odds for those kind of things. So £40–50 is pretty reasonable. £450 is a lot of money. It's too much. So you don't need to spend that much money to pass this exam. You need a reasonable, you need good tutors, a good clinical surgery, a good clinical supervisor, and something which is cost effective. And I think iMedics, we try to do that here. Both me and Dr. Mo have done well. I mean, my CSA score was 95 out of 117. So I think I'm in a good position, and same with Dr. Mo. I got a lot of the teaching from Dr. Mo. So I think between us, we've got a good mix. So we're probably in a good position to help. We've been helping students now for the last 18 months. The last couple of years, I'd say 2 years roughly now, isn't it? Since we've done not just the CSA stuff, but also AKT, MSRA, medical students, and of course, we do the international doctor exams as well. So, but thank you very much, guys. And thank you for your kind comments. And Ray, thank you for your feedback. That kind of stuff is always good. And we will see you guys at the next webinar. Keep in touch and all the best.
Perfect. This two last housekeeping things. In about 2 days, you'll get an email with a link for this recorded webinar, and you'll get the link to the next webinar. So join up for the next webinar within that email. So you'll get it very soon. If there's any topics you're interested in, please drop us an email at info@i-medics.co.uk. We can consider topics for the next webinar. And then the last thing, guys, is please share with friends and colleagues that you know, because most of our resources are free, like AKT question bank, PLAB question bank, MSRA question bank, and we can't do it without word of mouth. Like, if you don't let other people know, we're paying for our server costs. We're building the question bank. It's almost 3,000 AKT questions there. So if you can let them know. Roy wants the medical school webinar link. So VCAS, what I'm going to do, I'm going to jump out now. And if you don't mind pasting that in, we can cover some stats at some point as well.
Okay, so what I will do,
Adiniki, the question banks are free. So you just go onto our website, go to the AKT free question bank, add to cart, check out, fill out the registration document. It's like you can even use social media to log in, like Facebook accounts, and then you get your 3,000 questions straight away. They're all free. We've got a gamification, we've got a search feature, we've got the first AI tech built into it, which highlights your weaknesses immediately, and you can practice those questions. So please use it. Okay, there's the link for the medical school interviews. Guys, we're going to now start the next webinar, so take care, and we'll see you hopefully in 2 weeks' time.